Greetings everyone, Steve Cole here, and this is your refresher training on ventricular assist devices. My name is Steve Cole, and if you haven't crossed paths with me before, I've been in EMS. This will be my 30th year. I currently work in Southwest Idaho, although I've been all over the place a bit. My current function is an EMS training captain, and I am also an adjunct faculty at the local university. I have no financial disclosures. I'm not selling you anything. And I usually put up this picture here because it makes me all look prim and proper and professional. But anybody knows me knows that this is a little bit more like my style. So I just give you a little forewarning if I accidentally drop an F-bomb or say something that's a little bit wackadoo, you know where it's coming from. Okay, it's just part of who I am. All right, so let's move along. Normally when you build these courses for accreditation, they like a nice solid set of learning outcomes and objectives, but those, for everyday people, they make your eyes cross. So we try to tie those objectives into simple questions that you'd ask yourself to understand what you're going to get out of this. By the time you're done, we hope that you understand how a ventricular assist device basically functions. We're not going to make you a biomechanical engineer by any stretch, but just the basic idea. We're going to have a better idea on how to assess a patient with a ventricular assist device, whether they're in an emergency or you're just transporting them for some other unrelated issue. You're going to have some basic ideas on some do's and don'ts on how to care for these patients. And you're also going to have an idea of the logistical and operational concerns in transporting these patients. So all this, I hope, is going to be useful to you. So when we talk about VADS, what we're talking about is ventricular assist device. Now, most people talk about LVADs, but that's not the only one out there. We're going to clarify that. We will briefly, at the end of this, talk about a device called a total artificial heart, because those are out there, and they're often lumped together, but they are kind of different. You will hear the term continuous flow versus pulsatile flow, and that means two different things. So by the time you're done, you should have a better grasp on that as well. Let's talk about these little beasties. All right, so the name tells you what it does. It's a ventricular assist device. It assists with the forward flow of blood that would the ventricular contribution, the ejection of blood into the circulation, whether it be the pulmonary circulation in case of the right ventricle or the systemic circulation in the case of the left ventricle. It is implanted. And there are several different models that have kind of different approaches to this, but they all basically do the same thing. When you are going through this, there will be a attachment, a supplementary PDF from the International Consortium of Circulatory Assist Clinicians. These are perfusionists that are often nurses who follow up and provide a lot of the care for these patients in the outpatient setting. And if you can't find that, if for some reason it doesn't come through, you can't access it, go to mylvad.com, and you should be able to find it there under the professional resources. You will find these patients in all ages, from very young kids all the way up to the very elderly and everybody in between. Matter of fact, a surprising number of patients who are on the younger end of the spectrum, actually. The indication for these patients to receive this is usually some form of heart failure. So before LVADs, many of these patients were predominantly their only salvation would be a heart transplant, or inaortic balloon pumps, or ECMO, or something along those lines. So what a VAD does is it basically takes blood from the lower chamber of the heart, the right or the left side, and helps pump it to the vital organs. So it assists that. It doesn't take the place. Now, you can find a patient who has forward blood flow while the heart is pretty much either asystolic or in VFib, but blood flow is going to be less than optimal at that point, but you can sustain life. The idea is that the heart is still contributing something to the game. And what you see here, and let me get my handy dandy laser pointer. What you see here is here's the left ventricle. You see this graft here. So the ventricle still ejects up to the aorta. It still does. None of that's changed. The valves are still there, so on and so forth. but this device sucks blood in. It has an impeller. And when I say the term impeller, I keep thinking like the Caterpillar drive off a Hunt for October, but has an impeller, one ping only, all the way up through here, and ejects it into, or dumps it into, the aorta as well. So it contributes to forward blood flow, but doesn't necessarily replace it. Now, why is this important? Well, because these patients, after they have this implanted and they go through their cardiac rehab and they go through everything else they need to, are released back into the community. They live in a wide variety. These are not patients who are released back to nursing homes, although I guess that could be a potential end result. These patients often go back to a much more active, much more vibrant lifestyle than they have had for years. There's a particular lady that I can think of that has an LVAD who, after she came back to our own community, she started an LVAD survivors or support group. She dances. I can't remember if she did a full marathon, but she does walkathons. I mean, she puts young men half her age to shame, honestly. And she could do none of that with her heart failure before. So these are truly game changers for these patients. Now, as I mentioned, I live in Idaho, and we have some very rural communities. And when I say rural, communities are actually classified as frontier or super rural, who are 2 hours from a critical access hospital, much less a major medical center. And they live with their caregiver in these environments up in the mountains. So these really do enable a mostly kind of independent lifestyle that they haven't experienced. There are about 3,000 of these devices implanted each year, and that has kind of been plateaued the last couple years. But these patients are living longer and longer with less complications. And the reason why they're doing this is partly because of better medical management with blood thinners and such, and the design of the LVAD, or I shouldn't say LVADs, the VADs, actually have they've done some engineering tweaks so that they're throwing less clots. The body's tolerating them better. So these patients are doing better and better and better. When LVADs were first started being implanted back in the 90s and maybe earlier, survival to 2 years was remarkable, and now survival to 2 years is pretty common. What you'll see is the reason why people, like I said, most people, 80% will survive to 2 years, 30% will survive past 5 years, and I've actually heard of a patient that survived long enough to get her second VAD. The VAD technology, the VAD had improved far enough that there was a clinical benefit to upgrading her, and I think she'd been like 5 or 6 years, so she went and got another one. She traded her old Model N for the new Buick, so to speak. So that happens. These patients are living longer. It used to be that these patients, when they first conceived of VADS, what they were doing is they were looking for what we call bridge to transplant. And that was the majority of these patients initially. Trying to help them survive long enough to receive a heart transplant. Well, what they end up doing is making the bottleneck worse. So what happened is, you still had the same shortage of healthy hearts to transplant, but now you had more patients surviving longer, so your pool of patients needing those hearts got bigger. So then they started exploring what they call destination therapy. Instead of bridge to transplant, destination therapy. So these patients will have a VAD for the rest of their natural life. There is no plan to transplant them. This is their new normal. And they live relatively healthy lives. I mean, they're not going out and climbing Mount Everest, but they're doing some pretty remarkable things. There are some other, that's about 50% of the patients now are destination therapy. There's other subsets for the other 25%, bridge to candidacy, where they are trying to get them to survive long enough to see if they'll even be a candidate. These are really, really sick patients, even be a candidate for transplant. And bridge to recovery, these are patients who they hope they will help the patient survive long enough that their heart will recover enough function on its own and won't need the LVAD anymore. It's interesting. I was reading something the other day about COVID and myocarditis and inflammation of the myocardium and stuff like that. And it'll be interesting to see if we see a surge of patients who need LVADs or VADS in the future because of COVID, patients who survive COVID but have heart failure, because you can get a viral myocarditis and other things that can cause heart failure, and then we'll need LVADs and eventually go out in the community in the next 3 to 5 years. And that's just me speculating. I don't know if that'll be the case or not, but food for thought. So when I talk about VADs, there are really 3 different categories of VADs. There's LVADs, RVADs, and BiVADs. LVADs are on the left ventricle. RVADs are on the right ventricle. And BiVADs are not a new device. They're just a LVAD and a RVAD working side by side. So there are a few of those patients out there and that have 2 LVADs, 2 VADs in their chest, both functioning simultaneously. So they have double the fun. They have double the battery packs, double the controllers, double the drive lines, everything. That's just what they're doing. And there's actually some neat images on online of some of the early BiVADs that were pneumatically driven. So they had a pneumatically driven pump. Now they don't use those anymore because their complication rate was high. But where part of the LVAD is actually sticking out of the chest, it's pretty cool. There's something also called total artificial hearts, and as I explained, I will discuss that at the end of this lecture. Just a couple slides. They are often lumped in with these, but they're actually something completely different and require some special considerations. So as I mentioned, a BiVAD is not a new class. It's just 2 VADs side by side. I want to talk briefly about the driveline. The driveline has kind of evolved over the decades. And it's amazing to think that we're well past 20 years, 2 decades, maybe even 3 decades now of these being in common clinical use. The early ones, these were pneumatically driven, so it was a pneumatic line. I think at one time this was almost like a PTO pump, but now these are electrical lines that supply power and control to the device. So the device is here, the power supply and the control comes from the controller through this line. It's absolutely essential that these do not get damaged, kinked, cut, bent too hard, anything of that nature. Literally, their life, the sustainment of their life comes from the controller through that line. Now, there are other cables here you'll see that go to your battery supply. And again, this is just one type of LVAD. The flavor, the cosmetics of it look a little bit different with different models, but the basic principle is the same. You have 2 battery supplies. If you're swapping one out, you leave the other one attached. You never detach both of them at the same time. These connections are designed so that you can disconnect them in the field, but you have to consciously go through steps to do so. These aren't going to just pop off sitting in the car or anything like that. So here's the one that's most common in, this is not the one most common in our area. The other one is, but this is the Heartware. And you see it has a circulatory device. So it's like a little wheel that spins and pumps and comes off the left ventricle on up and then kicks out to the aorta. You have a Batman belt with your 2 batteries and your controller, and there's your drive line. This is the one that's more common in our area. So you have the controller. You have kind of John Wick style. Your battery slung right there, and you can see you have the impeller instead of the circulatory device. Now, what you'll find is that people get pretty creative. You see this gentleman with the Batman belt, but he's happy as a clam. He lives a fairly normal life. This young lady, however, I don't know if you can make it out, she's got a messenger bag. She slung it. And she has several different bags that matches her dresses and so on and so forth. It was interesting in that support group, when I was talking to the lady that ran it, one of the things that they help each other with is they make different bags and kits to carry their equipment in. So you may not notice that this is what it is in the heat of the call, so to speak. They actually, they make their own bags. They get very creative with this. All in order to live as normal of a lifestyle as possible. And here you see some other examples. This is a gentleman that has his, I believe this is a Heartware with his 2 battery packs right there and a single pack slung. You see this guy has a different one. And this is actually the manufacturer's one. And he has his John Wick style. He's ready to go to town. This guy golfs. This lady shops. This guy hikes. You get the idea. Now, this is a good general rule for any technologically dependent patient, not just LVADs. They all have a go bag, or they should. And they're very dependent on that go bag. So if you identify that they're technologically dependent, whether it be a vent, tracheostomy tube, LVAD, anything else, identify the caregiver, identify the bag, and bring the bag with you. Not in the car that's trailing behind, not that the family will bring that 20 minutes later. Have it physically next to the patient during transport. Murphy likes to screw with the medics who are unprepared. And if you don't transport this with you, you're asking for something to go wrong. I've seen it time and time again with a wide variety of circumstances. If you can bring the caregiver with you, that is a huge thing. Because I can tell you that unless you do a lot of critical care transports to these patients, they know more about this than you do. And they've received, when I say they received training, they've received sometimes 3 or more months worth of specific training on that device and that patient. They know it backwards and forwards. They've had to do test after test and workbooks and classes and reclass, so on and so forth before they're released out into the community. Now these are power dependent, so they will have battery packs, and these patients typically will have 6 to 8 batteries in their home, plus the 2 that they have with them actually plugged into the device, plus usually at least 2 more. Now if they have to plan their whole day around their battery management. So they will have maybe an AC/DC adapter, so on and so forth. If they're going on a road trip, they may have a small generator, something like that. They may have to plan stops to plug in and recharge, things of that nature. So pay attention to that. If you're doing a long distance transfer, make sure your inverter works, because you don't want to be in a situation where you think, oh, his battery's beeping low, I'll just plug it into this plug here, and your inverter wasn't checked before you left, and now you're in the middle of nowhere where the patient's LVAD is crashing. It's not something you want to do. So as I mentioned, critical connections, they really only come out when you specifically want them to. The driveline just don't mess with it unless you receive specific instructions from the LVAD coordinator. If you're going to swap out batteries, do only one at a time. And here's this. I believe this is the Heartwear, and this is the HeartMate. And you see they're very similar. Something else about these is when you look at the screen, they'll tell you what the flow rate is. And the flow rate usually sees patients with a flow rate between 4 and 6 liters per minute. Now this flow rate is dependent upon their hemodynamic status. And we'll talk about bleeding and hypovolemia and hemorrhagic shock with these patients in just a few minutes. So when you call the LVAD coordinator, this is one thing they're going to want to know. They're going to know the RPMs if it displays it, or they may have you push a button that displays it. So these can be adjusted to compensate for low flow states, but it's not something we're going to do without contacting the LVAD coordinator first. But these can easily be tweaked up and down in the field if we're instructed to. Let's talk about assessment. So when you're assessing the LVAD patient, the very first thing you should do, like a pulse check, is take out your antiquated stethoscope and listen over the chest at the point of maximal impulse or close to that. So basically fourth intercostal space, maybe a little bit lower, mid-clavicular line. And you should easily hear a whirling sound or a humming sound. You may even be able to feel it. Now, this is not something you need to listen exquisitely for. These aren't subtle S1, S2 sounds. This will be readily apparent. So if you don't hear it readily apparent, you know something's amiss. So that's the first thing, and that tells you that the pump is pumping. Whether it's pumping effectively or not, whatever, at least you know it's twirling its gears, so to speak. Then you'll make sure the cable's not kinked, not crimped, not cut, all the way between the chest wall, or actually it's usually about the lower, the epigastric area, all the way to the controller itself. Make sure the power is plugged in, so on and so forth. Now some LVAD, or I should say some VAD patients will have an implantable cardiac defibrillator pacemaker, because they still have a heart that's there that may need defibrillation, that may need pacing to keep it functioning correctly. Remember, the goal of the LVAD is to supplement the cardiac contribution, the ventricle contribution to the circulatory circuit, not to replace it. So ideally the heart needs to continue to at least try to carry some load. Now again, here's an example of a continuous flow LVAD, which most of them are now. Like I said, the original ones were pulsatile flow because they were pneumatic, and then they went to continuous flow with the impeller, which you can see right here. And I think that's a great little image of that. I don't have a great image of the circulatory one. What's interesting is through improved mechanical engineering and increasing tolerances, and now these are magnetically driven instead of a gear of some sort or whatever. A bearing, I shouldn't say gear, they were bearings. They were actually made from rubies, artificial rubies for whatever reason. Because they're able to do that with magnetic drives, they're now able to decrease the incidence of emboli and bleeding and other complications with these devices. So, interesting enough, the evolution, even in the past 2 years of these, has been significant. So it's entirely possible that what I'm telling you today is out of date, but in a year or two from now. So don't be surprised as this changes. We already talked about the flow rate is going to be between 4 and 6 liters per minute, ideally. When you're removing the clothes, be careful. I mean, these things go into the chest wall. They have to have sterile dressings over them. Just like, think of them as central lines. If you've done any work with central lines and you're familiar with how easily they become infected, that is absolutely something you need to be considerate of with these. Be really careful if you're cutting clothes off in an emergency that you don't cut the wires, the drive line. So that's what happened in this picture over here. Is I don't know the exact circumstances, but somebody somehow cut the drive line, and the patient was in extremis, in cardiac arrest. And what you see here is the physician actually used some MacGyver ingenuity and forceps and managed to thread all the individual splice the individual cables back together and get the LVAD started back up again, and the patient survived. So don't cut the wires. Don't get it wet either. All right. So as I said, I mentioned they're mostly continuous flow devices. So you should be able to appreciate a pulsatile pulse. You might. If you do, it's probably from the heart, its contribution. But there has been some experimentation lately with alternating RPMs. So it'll speed up, slow down, speed up, slow down to try to simulate the variance that you have with cardiac function. They're doing this because there's some theoretical advantage to decreasing bleeding with this kind of pulsatile flow of blood. I don't know where those studies have panned out yet or not, so that may or may not be something that endures. Let's see what else. Because it's continuous flow or mostly continuous flow, your pulse oximetry and your pleth, that's your pulse ox waveform, will not be accurate. So what do? You have to go old school. You have to look at signs of perfusion. Is there a brain working well? Is their urine output working well? What is their skin signs and their cap refill? Those are your assessment parameters to tell if you're oxygenating and perfusing. Now, your blood pressure, you're not going to be able to get normal blood pressure with the traditional blood pressure cuff. So, an NIBP from your cardiac monitor may be able to get a MAP. MAP is more important anyway for most of your medications. That's your mean arterial pressure. You may get a MAP if you're using a Doppler, but again, you have to really look at your other perfusion signs, your mentation, your skin signs, your urinary output. Throw an EKG on. Just don't be surprised if you see something weird. They may be an AFib, a flutter, a systole even, although that's pretty unlikely. They may be in a stable VT and have been in for days. They may even be in VFib. But like I said, if they're in VFib, they might be showing some signs of hypoperfusion. You have to look at your total patient context, not just to monitor, make treatment calls. Assess. You have a patient with an LVAD in front of you and it's right in your face and it wants to grab all your attention. You need to be very thorough in your assessment for everyday stuff as well, particularly traumas, falls. Remember, these patients are on blood thinners. They have all those risks that we'd think of. And because of that, they also, GI bleeds, anemia, chronic bleeding, shock states, stuff of that nature. Which leads us to our next slide. GI bleeding is the most common complication with patients on LVADs because they're blood thinners. They tend to be, hyper anticoagulated. As a result, GI bleeding occurs about 30% of the patients. And this, sometimes they have site bleeding and other stuff, but GI bleeding is most common. Here's the thing, is that chronic GI bleeding can make them hypotensive. It can make them anemic, which means they don't transport oxygen as well. And it can also, LVAD patients are very preload dependent. So this can mean that, you can look at their monitor or their controller and they're revving at 3,000 RPMs, but their flow rate's only, 2.5 liters per minute. Well, that's much less than what they need. They're showing signs of shock or, fatigue and everything else, or they might be doing okay with it. The body's kind of resilient. But that, you want to be careful. You want to observe for that. You want to ask questions about, have you had dark tarry stools and so on and so forth. The other complication, the far more serious one, but not quite as common, is the incidence of stroke. And again, most of these strokes are ischemic, although because of the blood thinners, hemorrhagic stroke is still a possibility. About half of these are fatal, much higher mortality than GI bleeds. This is a big deal. So you find a semi-conscious, unconscious patient, make sure you do your stroke assessment, your Cincinnati Pre-Hospital Stroke Scale, your VAN assessment after that, if that's indicated. Have a very low threshold for assessment for these type of conditions. Thirdly, another common complication is driveline infection. Just like with central line infection, driveline infection gives bacteria and other organisms a pathway straight into the body. That's why they are so particular about wound care in these patients. Originally, about 41 to 50% of these patients will get infected. Now it's about 20%, but still significant. And it's enough to be an independent predictor of mortality. So what's our role in this? Well, if we find them febrile, if we find them, kind of pre-septic, whatever the case is, this is one of our considerations. Ask some questions, pass it on. Make sure it gets passed on if you transport. These patients should be transported. These patients should, you get the idea. We already talked about that. Okay. So, treatment-wise, very first thing, verify the pump is on. It's as important as a pulse check. And then have somebody call the VAD hotline while you're doing it. Now, most of these units will have stickers all over them, on the controller, on the batteries to call. The family member should know. They might have a wallet card, so on and so forth. If not, there is a 1-800 number on the in the document that I'm submitting with this as well that you can call, and they can tell you, depending on the device, they can walk you right through whatever you need to do. Involve the caregivers. They know way more about this, as I mentioned, than you do. They've had extended training. Now, the downside is that if they could have fixed it before you got there, they would have, most cases. These patients are going to get vital signs. They're going to get the vomit care, vital signs, oxygen monitor, IV, and I can't imagine. Maybe I'm wrong, but I'd have to be really twisted my arm to casually treat and release these guys. They should be evaluated and observed in most cases if something happened that was serious enough to get us involved. Hypovolemia and low preload is the most common complication, so that's where your IV access and your fluid resuscitation comes in. But if you're going to do fluid resuscitation, it's not the 500 cc's, 1,000 cc's, 20 cc's per kilogram, 10 cc's, none of that nonsense. It's 200, 250 tops, low fluid challenges, reassess. Even a 250 cc fluid challenge can help them out quite a bit due to how preload dependent their heart is with these LVADs. They talk about using vasopressors, epi, norepi, so on and so forth. I haven't heard of anybody who's actually had to do that except in the sickest of the most sick, and usually it's only after they've tried everything else. So you're definitely not going to go to vasopressors as your first choice. So let's talk about ACLs. They're in cardiac arrest or they're about to be in cardiac arrest, and you're looking at them like, what do you do? Well, your airway and respiratory management, that doesn't change. They can have ET tubes, LMAs, CPAP, iGels, you name it. All that's pretty much okay. You can defibrillate them if you feel you need to. But if you have time to consult the VAD hotline first, feel free. that's probably what you want to do. These devices are grounded. You're not going to short them out. You're not going to burn them. You're not going to burn their heart, conducting current straight through or any of those things we used to be considered about. However, there are some special considerations. It's not so much that they don't want you to defibrillate. They want you to try other stuff that's more important first. If you are going to defibrillate, don't place the pads directly over the device or the driveline. But what you can do, and what they recommend, is probably, and I'm saying this as a general recommendation, not as an absolute, consider anterior-posterior instead of apex sternum for your pad placement, which incidentally is the same thing you want to do for your, if you have a pacemaker defibrillator in place anyway. Change the vector. These patients, even if they have chest pain, they're so preload dependent. Think of it as like right heart failure. So preload dependent. You don't want to give them anything that's vasodilatory. So no nitroglycerin, nothing of that nature. If they have VTAC, VFib, some other dysrhythmia, and you feel really compelled to treat it with an antiarrhythmic, talk to the VAD coordinator first. The VAD won't affect your medication per se, but these patients are by definition complex, and the VAD coordinator may have some insight into either something that may be more effective or the underlying pathology that may inform whether you really want to give that antiarrhythmic or not. And like I said, CPR, it's a last resort. We used to be concerned, oh my God, you do CPR, it'll tear the LVAD away. Practice hasn't demonstrated that's as big of an issue as we thought of. Now, I've even heard, and I don't know what the outcome was poor anyway of a Lucas being used on this. I don't know if I'd recommend that. But manual CPR you can do. But again, call the LVAD coordinator. They're going to have 4 or 5 things they want you to do before you do CPR that may impact your care. They may have you increase the RPMs. They may have you increase the flow rate. They may have you change out the battery. Something like that will make CPR not needed. So keep that in mind. So finally, logistically, I think I mentioned this already. Always take the go bag with you, with the patient. Take the experienced care provider with you, not 20 minutes behind you, but with you if possible. And I know in COVID they're restricting a lot of visitors, but this is an essential care provider. Call ahead to hospitals, see if they'll let you bring them. And usually when they hear the word LVAD, they're happy to have the help. Remember, these patients already have comorbidities. They have all the same stuff that our other patients do. Heart failure, strokes, diabetes, everything else. Don't get focused in on the LVAD. Be very holistic in your assessment and thorough. And as far as transport destinations, God, this is such a variable thing because we all come from different communities, right? But like in my area, we have very few tertiary care facilities, but where I came from in Middle Tennessee, you have one on every street corner. So you got to know your system and figure it out. Don't figure this out at 3 a.m. when you have a VAD patient crashing in front of you. Figure out either by protocol, by talking to your docs, or whatever on what the best options are in your area. With that in mind, consult the VAD hotline. If they're from a hospital in your area, then that decision is easy. I tell you where I wouldn't take these patients, though. I don't think I would take these patients to your local critical access hospital unless you had no choice, or your local freestanding ER unless you had no choice. So finally, we're wrapping up. I want to take a moment to talk about total artificial hearts. Now, you still see these, not a lot, but you still see these a little bit. Now, these are completely different from LVADs, but they often get lumped into the same kind of category because they're for heart failure patients. This is one of the first ones. This was pneumatically driven. They're quite a bit different now. So what a total artificial heart does, I'm going to go back to this picture, is it essentially replaces the ventricles completely and most of the atria. So there's not much heart left at all, right? So with that in mind, the total artificial heart actually produces a pulsatile waveform by its chambers, where the VAD usually doesn't. The VAD, because it has a heart still in place, you can have an EKG. You will either have asystole or maybe maybe some SA activity, but no ventricular activity at all. You don't need any nitro here because VADs are preload dependent. You can give nitro and artificial hearts in place, but you probably won't need to. But again, you need to make sure the blood pressure is fairly high. And this is good practice anyway, honestly, guys. You can cardiovert and defibrillate VADs. You can't cardiovert and defibrillate total artificial hearts. It won't damage them, okay? It won't damage them, but there's nothing to respond, so you're wasting time. You can do CPR on a VAD. It's not your first choice, but you can. There's nothing to compress on a total artificial heart, and that'll become evident in the pictures I'm about to show you. And the risk of damage to what little tissue's left and ripping away the artificial heart actually is a little bit more real here. Because there's a myocardium left, you may have an ICD or pacemaker. Not the case over here. So as I said, it's surgically implanted and it's got 2 chambers, so it's technically a BiVAD, I guess, is one way to think of it. One of the reasons you see this instead of an LVAD or a BiVAD that we just talked about is that it takes up less chest and less space in the chest. So you'll see it with sometimes with peds, or you'll see it with patients whose myocardium is so sick it was not salvageable. So here you see an example that you have the myocardium. They literally sever the ventricles and part of the atria. They graft in these connections, and they plug in these 2 chambers, and there you go. Now, so basically what you have is the entire lower portion, basically depending on where it's grafted. This image shows that it's grafted directly into aorta and vena cava. My understanding is that they don't always do that. They sometimes have some of the atria left. I'm not sure what tips them one way or the other. But you'll see patients with this. This was a guy who had a rare congenital cardiomyopathy and he has a BiVAD in place. And you see these are pneumatic lines here with a compressor. So this is kind of a different technology. But this gentleman lived over 555 days. He made it to transplant, and he did quite well. So that's all I have for you. I hope this was useful, and I hope that you're gaining something out of this. Again, if you can't find that document in your materials, go to mylvad.com and get the latest and greatest. And you guys be safe out there. Thank you.